So Dr. Louis Chen completed his degree from Columbia University and graduated top of his class with highest honors and distinction. He was inducted into OKU and received numerous accolades, such as the Apple Scholarship for the Most Outstanding Graduate and the New York Academy of Dentistry Exemplary Professional Conduct Award. Since his residency at the Bronx VA, he has pursued both practice ownership through acquisitions and de novo build-outs with his business partners. So everyone, welcome Dr. Louis Chen.
All right. Welcome. Thank you for all joining on after lunch. And I'm actually taking a break from seeing patients to make this happen. I'm excited to be here. Thanks for, again, spending your Saturday with me. I'll keep it brief so I can open the floor up for questions. So I know we want to, I'm talking about cosmetics and practice and what that really means. And, I wouldn't say I'm the god of cosmetics, but I do a lot of cosmetic. Interestingly enough, I just did 2 same-day bondings in my chair because of the patient wanting to lengthen her teeth. I wasn't able to upload and change my slides. But I want to talk a little bit about cosmetics and what we're looking to achieve in a dental practice. And I'm not so sure. I wish it was in person so I can have some engagement with all you all, but it's a weird time to be virtual. So again, this is my email if you need. This is my social media handle if you'd like to contact me by any means. That is available. Cool. All right. So a little bit about my background. Let me see, does that go? Is it going through? Oh, here we go. So a little bit about me. I was a graduate from NYU with a degree in economics and a minor in chemistry. I also went to Columbia Dental School, graduated in 2016, so not too long ago. So I remember dental school very, very clearly. I became clinical instructor in Columbia as soon as I got my license in New York. And I did my residency training in James J. Peters VA Medical Center, which is also known as Bronx VA. And to be honest, I think I basically learned all of my clinical education in residency. So I spent 2 optional years at GPR, one mandatory year and a secondary optional year, where I kind of continued to hone in on my skill sets. And I am where I am today because of residency. And I want to just preface all this by saying that if you have the opportunity to enhance and continue your education and be the best you can be, go for it and don't think about the time that you're losing. If anything, this is time that you're investing. So let's talk about a little bit of aesthetics. I have a lot of slides. I'm going to breeze through a lot of these clinical cases and kind of talk to you about what are the considerations in cosmetic dentistry. Again, some people have differing views of cosmetics. Some people don't think about certain aspects of cosmetic dentistry. And I'm going to introduce some of these concepts so that moving forward, as you start to see patients, you can start seeing patients in a different light. And a lot of it is not aesthetics, actually. So again, this is one of my cases in residency. I did a lateral incisor fracture, and I did a atraumatic extraction, and ultimately a couple months later, have a final restoration done. Is that aesthetic? I'd say so. After his initial presentation. So my personal perspective on cosmetics is as such. I like to focus a lot on function, which is my primary concern, occlusion, biology, and aesthetics. So those are my 4 top things in that order. So this is how I decide whether I can pursue some sort of cosmetic work, or I can say, you know what, maybe you should not do anything at all. So again, I'm going to go through this kind of not really a checklist, but functionally, cosmetic dentistry can only be achieved if we can understand the patient's function and occlusion. Because if a patient's grinding, how are you ever going to put veneers on? Or if a patient's grinding, are you going to design a crown, and how are you going to design the crown, right? So, great example from functional standpoint. What is it that needs to be done to restore the smile? Are there missing teeth? How long have they been missing? Are there any tooth structures that's missing? Is the patient a grinder? Are there any flaring anterior dentition? Any existing restorations? Why were they done? Occlusion is basically, we'll look at their current occlusions, class 1, 2, 3. Is it a skeletal issue? Is it a dental issue? And can we reconstruct their mouth and be able to provide them with proper aesthetics, given that the occlusion will allow for that? So then biology, of course, perio, endo, caries control. And lastly is actually aesthetics. if I can achieve the function occlusion in biology, I know that at the minimum that I can achieve whatever I want aesthetically, because I know functionally after the work has been delivered, this patient will walk out just fine. So this is my personal perspective. I look at patients not because they need a veneer. I think about their excursive movements. I think about their wear facets and how long they're wearing, so on and so forth. Okay. So some of my cases in residency, again, this guy, perio control, was able to, I just try out different designs for fun. Literally it's LOL. I was like, oh, I'll do an onlay here, I do an inlay here, I did veneer there, crown there. And the reason why I did it is not because I wanted to just do it for fun. It's for me to understand if we really need to just prep crowns all day, right? Or do we really need to just, if we really need to just, prep veneers, and where do we prep veneers? What about onlays? Can we conserve more tooth structure and prep for an onlay? So this is actually a mixture of different onlays, veneers, crowns, and inlays, because I just wanted to see that can I still achieve proper aesthetics, function biology, occlusion biology and aesthetics by trying out different ways of delivering this work. Same thing here, same day composite bonding, 7 to 10. He did DIY ortho. He wanted to close the spacing between the teeth, but obviously by doing so at night, he's created interproximal decay from 7 to 10. So of course, same day, I said, why not? I just lengthened his teeth too, and I fixed his decay. Another case, so came to my prior practice. This person came to my office, literally said, I lost my crowns at the beach when the wave hit her in the face. So obviously you can see why it came off, and you can just see that there's so much interclusal space for longer ferro, a longer clinical crown for ferro, but some people don't plan their cases well, right? This is why I talk about, understanding their existing restorations, what's underneath it, their function, biology, so on and so forth, because then I can design the case. Same day, spent 3 hours kind of creating shells out of nothing and gave her something to walk home with, which is semi-decent for her coming with nothing. And I've gotten better with photography. So this is one of my cases in prior practice, same thing, same day, bonding from here to here. Another case in prior practice, this is my full mouth reconstruction case. Very white, but he wanted it that way. Again, this is a full mouth recon, full mouth, all of crowns, implant crowns, so on and so forth. Not for everyone to just touch and do, but if I could understand the occlusion and understand his function, I can deliver this comfortably. And recently I did something like this of this nature here, where this guy was going to a wedding, an engagement photo shoot, and he emailed me at 10:45, and I responded, and I said, come on in, I'll fix you up. And this is the same day response. So I've been touching more and more into composite dentistry and straying a lot less away, staying away from veneers, because I think there's a lot of artistry in freehanding your work or having a stent or a mock-up to, bond teeth. And it's not just slapping on composite. There's different layers of composites, right? As you can see here. And then a multi-layer bonding with composite with A2D, A2B, A2E. So I have different layers of opacity. So this way I can cover and mask some of this translucency over here and kind of mask it over here. Of course, a lot of the times, if we don't understand science and the science behind prime and bond, I noticed that a lot of Stanford students, a lot of my associates of mine, they use prime and bond as a wetting agent. But in theory, that's not truly a good wetting agent, correct? Because prime and bond actually has solvent in there, which is ethanol, right? So sometimes that doesn't fully cure. And what ends up happening, you have layers and layers of composite, all right? So what I usually do is I use flowable as my wetting agent because it's still resin. So I use that flowable as my wetting agent, and I start to compress onto the tooth and start to, smooth it out. So over time, it takes a little bit of time to layer this composite. You have to do a nice polish, and here's the final outcome. That was him. This is the case I talked about full mouth rehab. very, very difficult case. You can just see, again, functionally, look at his wear, look at his bottom anterior teeth. All right. And again, I like to try to work with occlusion. I like to understand occlusion as much as I can. So I, waxed up his teeth, and I did a same day 12 to 20 teeth bonding to open the bite and manage it. But of course, with grinders and composites, you know that composite cannot be, do not have the same compressive forces. So it ends up looking like this because of marginal leakage, things happen, food dies, so on and so forth, even though it was nice and clean. So whatever, I said, okay, that's my mistake. Now that I've opened a can of worms. So think of it this way. I opened up his bite with composite, not knowing that this would happen. Now I'm at a point where I have basically committed him to a full mouth rehab without thinking so thoroughly about his function and function and inclusion. So I have no choice but to fix the situation, right? So I have to do a full mouth rehab, right? From here to here, temporaries, managing the bite. And his crowns and final outcome from here to here to here to here. So back to the basics. So I want to focus on the fundamentals. Again, if you don't have a camera, this is my current camera setup. It's just take it with a grain of salt. This is many different kinds of setups. This is just strictly my setup. I have a DSLR. I have a transmitter, speedlight transmitter here. I have the speedlight flashes on either side, and I have the soft box diffusers with a bracket that supports it. Again, that's personally my setup. It doesn't have to be your setup. It works for me so far. It's been good. But again, if there are any other alternatives, you just let me know what you like to, there's Nikon has other, DSLR cameras, but Canon is what I've been choosing these days. So the reason why it's important to take these images is because ring flash does not give you the same effect as a twin flash. So the difference is pretty significant where the left image here is very flat. So you don't get to see the true anatomy of teeth unless you transition to something more advanced like the twin flash, where you can actually take pictures and the lights will bounce off line angles more accurately. So you can actually start to look and analyze the anatomy of teeth, and if you need to adjust the surfaces of the teeth to create line angles, that's how you could better judge it. So let's talk about these a set of concerns. And there's a textbook from Stephen Chu and Dennis Tarnow, and it talks about understanding how to manage occlusion. So one of the things that we look at is anterior determinants. So again, this is recorded. You can take a look at this. I have the resource here to the bottom left. Some of the things that we look at when we look at aesthetics is understanding the bite. So there's different kinds of bites, A, B, C, right? One has a very flared out dentition, one has a steep bite, and one has a normal bite. So you can look over here. A refers to flat, so it's kind of flared out. B is the average, which is most normals, most people's natural bite. And C is steep, very, very sharp and deep, right? So we have to understand the anterior guidance, because that will determine how teeth will start to, in protrusive movements, how that will glide off and open the posterior dentition, right? So I kind of highlighted the important areas here. So when restoring the anterior guidance of the patient, it's necessary to develop the flattest possible guidance to allow disclusion of posterior teeth. So if you look at it, A, it's very flat, right? B is normal, but look at C. Let's kind of go back into this concept where in occlusion, where maybe most people don't really talk about, is the envelope of function. If you have a very, very steep and anterior guidance, you really restrict the patient from actually guiding, right? Imagine if you're locking yourself in and your maxillary and mandibular anterior teeth are just kind of really telescoping over each other. If you want to move forward, you just simply cannot. So you are restricting their envelope of function. That's what they're kind of alluding to. And then look at B. Right here, a more hollow contour of the upper palatal surface allows for more freedom of movement and more progressive disclusion that tends to lead to less force on maxillary teeth towards the buccal side, right? So imagine if you were to protrude, you would have more disclusion as a result than like parts within the scenario C here where you're locked in. And A's, forget about, your teeth are just flying, right? So this is actually really important because look at veneers. This will determine whether or not you should put veneers, and this is going to help you design your veneer prep, whether it's a window prep, whether it's wrap prep, size of wrap, because this is where, because at the end of the day, when you go through protrusive, you want to make sure that their lower anteriors are not forcefully maybe nicking off or popping off those veneers. So it is important to have the patient look into the patient's protrusive guidance or anterior guidance. Great example here. Anterior guidance is to be in harmony with the envelope of function, right? This is very classic example of something like C, where the maxillary and mandibular teeth are so steep, the occlusion is so steep that it creates this kind of barrier that prevents the patient from actually protruding their teeth, right? This is called the envelope function. They cannot possibly protrude. You see this typically in class 2 deep bites patients. Again, as an example. So this is what we're talking about here. A moderate overbite over jet is often found in class 1 patients. This is B right here. When the mandibular incisors contact the palatal surface of the antagonist, the teeth are in ready situation to guide as soon as the mandible protrudes. So basically it's saying that as in this scenario here, if the moment you protrude, you're discluding your teeth. And that's important because this concept is called mutually protected occlusion. And I'll kind of revisit that a little bit later. So, but mutually protected occlusion, if that's not, if that's new to you, that's also called anterior support to posterior, posterior support to anterior, or canine guidance, or arterial guidance. Again, this is about smile line, right? So in order for you to determine when to lengthen the teeth, you ask them to smile. Sometimes they say the E. E is a great word. Just ask them to smile normally. If they're less than 50%, you can lengthen it. If it's over 70%, it's too difficult to lengthen. 1, because it's unesthetic. Number 2, it's the teeth are way too long. So you can't lengthen it further because there will be more issues than not. So in this scenario here, this is why it's important to understand both the posterior determinants of occlusion, which is back teeth. In order for front teeth to be sustainable, back teeth must be sustained first, right? So think about it this way. The molars are meant for function. If we don't have a sustainable posterior dentition, then we are essentially having the patient destroy their front teeth because that's the first area they're going to feel comfortable chewing with. So usually before any aesthetic sort of work, it's important to understand if we can manage the posterior occlusion. So in this scenario here, you have a missing tooth on the bottom right, or this image here, their patient's bottom right. And after that, you can kind of open bites if you have to, you can lengthen teeth if you have to, because at the end of the day, patient's gonna use their back teeth, not their front teeth to function. Great example, there are different ways, different kinds of full mouth rehab aesthetic cases, right? 1 single tooth versus four teeth versus a full arch, and the top and bottom are the chaotic ones. And this is the biggest PITA. How do you record this? Because there's no vertical stops, right? And that's something that, that's a full mouth rehab way of thinking for cosmetic cases. Sometimes you want to not do this. Again, I don't want to expose you to different kinds of scenarios that, cosmetic is great, but we have to look at other things outside of making people look pretty. Hence, you need an articulator. And most importantly, you need to understand how lab technicians work, because in order to save yourself from this, you better call your lab and ask for help. Posterior determinants. Very simple. I'll breeze right through this. Basically, posterior determinants depend on your cuspal inclines, your non-cuspal inclines, your condylar inclination. So with a steep condyle, which is, B1 here, like this, the cusp can be made longer. Does that make sense? This is your condyle. It's pretty much the same. And if the condylar inclination is flat, then the cusps are flat. This is almost, it's not true science, but this is almost coincident with Bruxers, that when people grind their teeth are flat and their occlusion, the cusps are flat. So therefore their condylar inclination becomes flatter, right? Because there's no cuspal inclines to support the condylar inclination. right? So in turn, the teeth are flatter because they are grinders. So VDO, VDR. Most important thing people always ask is how to open bites? And people think in dental school that opening bites is taboo, and some would agree, some would disagree. Actually, I open bites regularly. And if you can manage bites, then you can understand how to manage full mouth rehab and manage any case, actually. So the first of all, most important thing is freeway space, right? Freeway space requires, you require 2 millimeters to be adequate. So that's when the vertical VDR minus VDO is equal to 2. So VDO refers to vertical dimensional occlusion. VDR refers to when it's at rest. So one of the easiest ways to identify the VDO is ask for the patient to say 60 to 69, because you can then identify whether or not you have excessive VDO or deficient VDO, because that's when the mandibular, maxillary and mandibular teeth touch very, very closely, but they don't contact. So if you have a lot of shushing, it's because the teeth are touching so closely that there's no opportunity for air to pass through between the space to create an S sound. So they shush. So when you have the deficient VDO, when it's too close, they have more of a hissing sound because there's too much air passing through between the teeth. So where do you draw the line? So if you have the freeway space of 2, you're pretty much in line and you can open bites. And VDR, I typically like to say Emma, just to see, kind of where, your lips rest and how much space that I have to determine if I have enough freeway space for their restorations. Considerations when you open vertical. Ideally, the reason why we open vertical is because we want to restore what's lost, right? So we can, by restoring what was lost, we can eliminate occlusal interferences, right? We can create proper overjet and overbite. We can alleviate steep anterior guidance by redesigning their aesthetic anterior palatal, features, because we can minimize broad anterior contacts. And the question is steep anterior guidance good? Yes, if you have posterior dentition. No, but you will worsen if it's no, because you will worsen anterior wear. So these are some of the considerations when you open vertical is, well, are you able to kind of manage your anterior guidance as a result of opening the vertical, right? So another thing we look at is centric relation. Articulators. You need this thing if you do full mouth rehab, unless you find other shortcuts to translate midlines and interpupillary lines to the lab. Because otherwise, if you give them a lab, they're going to think that this is a complete plane and you're designing a case on a cant. So it is important to understand, if you are correcting a cant, that you try to have an articulator ready and a face bowl, so this way you can translate that in an analog way. In summary, this is pretty much the 101 of function is anterior guidance, which is that allows for disclusion of posterior teeth and movements, right? Side to side, canine guidance, protrude forward. So you want to minimize posterior interference. So in essence, in protrusion, only maxillary and mandibular incisors touch, where canines and posterior disclude, right? In lateral excursive, only canines slide and disclude both the ipsilateral and contralateral posterior dentition. Posterior guidance, basically the flatter the condyle guidance, the flatter posterior cuspal inclines. That means it's their teeth are flat and they're pretty much grinded down their teeth. And the steeper the condyle guidance, the more cuspal inclines there are on teeth. So ultimately, this in essence means it's mutually protected occlusion, which is front protects the back protects the front. So in order for the back teeth to be stabilized, you need to make sure that when the patient is going through anterior guidance, that the back is discluded. And if in normal occlusion and centric occlusion, if the back teeth touch, they're protecting their front, because they're not just damaging their restorations or any of their natural teeth. So this is where I was, all the images, and I was a baby Goku. I'm always thinking about learning how to improve. So I'll show you some of the cases when I was at dental school with D3 of my poor, blurry ring flash DSLR that was provided and I took. I didn't know how to use a camera, but this is one of my cases, right? My gums keep bleeding, right? Strip that off. nasty. So of course, if you don't understand how to manage your FPD Pontic design, you get something like this, which I had to redo. But I'm going to breeze through this because I want to show some other cool cases. So, and I want to open the floor up for the questions. So again, you make it temporaries, and what I did to heal, to kind of have the tissues, heal, and I actually create a space under the pontic area here. They don't even touch the soft tissue. So I want the tissues to breathe and heal. So in 1 week's time, look at the soft tissue. It just shows you that poor design leads to poor results. And of course, what's wrong here, I did a pickup impression for a full, a long spanning bridge. But if you look at this, there's so many issues, right? If you do the pickup impression, if my PVS goes underneath the copings, that means it's not fully seating on the tooth. Look at these blebs here. If you see this little darkness right there, that means I pressed too hard into the impression tray. If I press too hard into the impression tray, that means that area is flat on the model, which actually messes up with the mounting, right? Because you want to make sure that the mounting is as accurate as possible, right? So there's a lot of things you can learn from just looking at your cases. That's why it's important to take pictures. So what else could we do to be even more accurate to verify clearance or remount prior to applying porcelain? So again, you have this impression in coping, these coping that kind of verified, seated together. And how do you determine whether or not you have enough room for porcelain, right? Because as a PFM, you need some sort of restorative room. And I always kind of go through this, and I'm more than happy to share these slides with you too. Shim stock. Shim stock's great. So shim stock is basically to identify, one, when you put these copings in, are they touching the teeth? Because you want to make sure that when porcelain is applied to these copings, are you going to open the vertical? So shim stock's probably the thinnest articulating paper that you have, and I'm sure that the module that you have and where you get your equipment will have shim stock. If not, it's a great thing to have after you graduate. This is the thing, is so thin that you place this, you slide this through on this area where all her teeth are touching, and you will see whether or not the teeth are touching with and without those restorations. If you are pulling the shim stock in one area, let's say this canine here, this really nice contact. If you're pulling the shim stock through in this location with and without the restorations, that means your vertical is maintained, right? That means that this area is stabilized. So that's how one way you can actually identify without prepping and drilling too many things is to see whether or not this area here, this solid vertical stable location is either open or closed with shim stock. Yeah, I'll talk about that later. It's called a semi-precision attachment. But another case, D4, baby, like I said, baby Goku, crazy case, you can see that this is actually central canine lateral. So central canine lateral, not central lateral canine. So weird transposition case. Again, learned a lot from this case. Again, I did not stabilize her posterior dentition. You can see it from here. There's no back teeth. So I restored her actually with no posterior dentition support. My preps, I did my own wax up and my own guide, my own reduction guides, temps, not too shabby. No endo, no pulp out. Again, clinical skills is really, really important. And that's the result for attempts. And final result. Didn't love it. Again, from a perio standpoint, what are you going to do? How much are you going to lengthen the teeth to make her happy? So again, what did I learn from this case? I need to stabilize posterior occlusion first in order to manage those anterior restorations. And of course, manage your prep design. Don't over prep. Whoops, what did I do here? Don't over prep. Where I am now, just regular, Goku, not like Super Saiyan mode yet. So again, case I did in residency, a very, very crazy case. Looks simple, very difficult. You can just look at the deep bites. Look at this mandibular incisors intruding as a result of a deep bite. reverse occlusal splint plane, worn dentition, no posterior stops, so on and so forth. Inclinate, like, look at this mesial inclination of these WYSIs, all right? And I don't have all the cases, the step-by-step process, but again, what do I need? Again, function, occlusion, biology, aesthetics, but I want to kind of go through to some other cases that I'd like you to see, but same thing, not too bad. So what I did was I used my provisionals as a test run. So the most important thing is, in order for you to confidently determine that a patient will sustain their bite, is to give them provisionals. So you can see right through, I actually drew the line. I actually lengthened this by this amount from from his initial presentation. I lengthened maybe 2.5, 3 millimeters as a result of me opening a bite. Because I can open the bite, that gives me the opportunity to lengthen teeth comfortably, because that means I can manage his anterior guidance, and I'm comfortable. And these were veneers. And this is magic. Voila, from here to here. Sinus lifts, bilateral sinus lifts, implants, crowns, always, veneers, composite bonding, you name it, from here to here. It took me 1.5 years to finish. Another great case. Look at this. Class 3 bites. How do you restore that? Right? Again, same thing, same concept. As you can see, the wear on his teeth, right? If it's worn down, there's no cuspal inclines. Therefore, it's because his condylar guidance is steep, like flat, right? So back to the drawing board, what do we do? So in one day, I actually prepped all the teeth and removed all decay, because don't forget the basics. If you're opening, people over prep when they open VDO. When you're opening VDO, you have to prep less because you are creating more restorative space by opening the bite. I'll repeat that again. When you open bites, you're able to prep less because you don't have to, you are creating more restorative space because you're opening that bite. So don't think that you're opening bites means you have to prep more. You actually prep a lot less. So I basically just kind of polished everything, removed all his existing composites, polished it. One visit, I didn't have this video in here, but this shows you the wax up that I had and these bilateral implant restorations that are provisionals. And I opened a bite 5 millimeters in one visit from here to here. And these are all splinted here, composite. From here to here, that's 5 millimeters of opening, and he was totally fine. And this is how he looked like. Substantial. I opened a bite a lot. It looks like more than 5 millimeters. And again, opening the bite is very, very significant, but also it needs to be very precise, because you have to understand, are you opening the anterior bite or are you opening the posterior bite? And that's very specific to the lab, and the lab needs to know, and you need to guide the lab into allowing for a predictable restoration. So again, with any case, it's always important to also use clear liners as an opportunity for you to achieve aesthetics. This person came in with an initial Invisalign, was working with an orthodontist. Same thing here. Look at the gingival zenith levels. The gingival zenith levels was a result of the inclination of the teeth, rotation, so on and so forth. You can see they're off. So again, you can see my picture taking has gotten better. A lot more depth into pictures, a lot more detail. And then he was going to get married. So I said, all right, cool. Let's prep you up a little bit. Again, with ortho, managing the gingival zenith levels, kind of bringing it down a little bit. Prepped it very, very minimally. Again, you don't prep initially just like a veneer for temps. You kind of just polish everything off, just you want to lock on some temps. These were my final preps for that day. Again, made temps. Now he's back. He needs new temps to finish his Invisalign. Same thing here, more spacing. Again, that was part of the plan. From here to here. Temps. This is my final prep. Again, I did not pack any cord, depending on soft tissue biotypes. It's really important when it's thin or thick, when to pack cord. Again, minimal prep design, very minimal, less is more. And I use, again, reduction guides to get this outcome. But I want to wrap this up quick because I want to make sure we have a lot more discussion, because I think there are people who are asking questions, and I want to make sure we can navigate those questions with you guys. So I'm going to just breeze through the very end and really kind of go through some things. Is, this is where you want to be as well. But most importantly, excellence is not an art, is the habit of practice. So everything that you do and you see came from a lot of planning, a lot of thinking, a lot of ups and downs to understand. You got to beat yourself up to understand how you can get better. And it's really, really important to understand the science behind it, not just because you're prepping crowns. Understand why you're prepping crowns and why you're trying to achieve aesthetics. Again, sometimes doing aesthetics it's not easy. It's difficult because if you don't manage it, think thoroughly, if a veneer pops off and a crown breaks or onlay breaks, how do you manage that? How do you set those expectations with patients? And that's one of the most important thing is try to think very thoroughly before just offering someone, hey, I can do those 2 veneers, right? So I want to open the floor up. I want you to know that if it's worth doing, you're in dental school, it's happening now. I know it's a weird time to be in dental school, but if it's worth doing, if it's worth doing, it's totally worth overdoing. So keep at it, keep doing well, and keep crushing it. So let's open that floor up.
Perfect. Thank you so much. So we will stop screen sharing for the question portion.
Cool.
And I've gotten a whole lot of direct messages. So I will, I'll start with a couple of those. So let's see, the first question is,
I see a lot of familiar faces.
Yeah, now you can see everyone.
Yeah.
So the first question is, Dr. Chen, would you recommend veneers to a patient who has had composite on the incisal edges of a maxillary anterior tooth and it is repeatedly falling off, or is there a different way to manage this?
Well, same thing, function, right? I look at function. There's a reason why anterior incisor composites break, because maybe in posterior anterior occlusion, or they're biting to something, it pops off. Again, composite is not going to solve or manage their bite. But what you can do is understand through the excursive movements, are they popping off these restorations as a result of poor management of their bite? So that's the first thing, is go through excursive. I tell them, hey, go to canine guidance, go protrusive, and I tell them to stop exactly where it breaks. And then that's as far as I lengthen and I call it a day. So I don't go further than that. So ideally, I don't do veneers. Again, aggressive for me. I'm more interested in doing composite as an art, and it's been very, very humbling to see that you think you're good, and then you take pictures, and there's a lot more room for improvement.
Awesome, thank you. So the next question is, how or when did you get involved with social media? When did you begin to see an impact of social media on your work?
Actually, social media is not more of a personal thing. It's more actually me connecting with a lot of people around the world. I've gone to know so many amazing clinicians as a result of me being on social media. And I will say that if you utilize social media appropriately, it is a form and an avenue for you to learn. I have learned a lot of different techniques from great clinicians who are colleagues and friends of mine now, because I was able to, openly ask questions that I would not be able to ask in a clinical or classroom setting. So don't be afraid to ask people questions who are, substantially better. I think there are a lot of people out there who are just very, very giving.
Awesome, that's a good take. So another question is, in order to get better or more comfortable with cosmetic composite restorations, do you think it's better to practice more on typodonts or do CE courses, or just practice through real patients?
Ideally, not on real patients. I've always loved doing it. I never took a CE course, but I see people, Jacob has been asking about body shades. So some companies have different shades. They have dentin shades, they have body shades, they have enamel shades, they have translucent shades, white shades, and they're all used to manifest a specific color at certain areas. Doesn't necessarily mean dentin means it's just for dentin. It's just a very dense color. So where did I learn it? I learned it by actually seeing on a patient where I was working on a discolored anterior tooth through root canal, and she didn't want a crown. She wanted the most conservative option, and that was the first eye-opening experience. When I already have these materials, I said, why not try to mask it? So again, applied a little bit of common sense to say, okay, you know what? I need to mask a yellow tooth. I must mask it with a very, very opaque color. And I started playing around with it more. I've been trying to work with different thicknesses of composites. And again, I had my associate buy a typodont, and we've been working on it together too, just to learn how to manage composites. And as a result, I've gotten better and faster, and it keeps me humble. And I'm always working on it now these days.
Awesome. So the next question is, do you have patients come in wanting a brand new smile and yet are suffering from perio disease? How do you explain to these patients that they need to take care of their active disease first?
I refer them out. I just say, listen, you got a lot of things going on. I think that you should manage your oral health first, and that your aesthetic concerns can be addressed after your teeth are managed well. And that's probably one of the biggest things that I tell patients, is that you first need to know whether or not you can manage it, right? If you put things on a perio patient and things fall off, they're going to come back to you and say, why are my margins showing now, right? So I want to make sure that my expectations, and most importantly, it's all about setting expectations. Let the patients know what you will anticipate. And we don't want to just say slap on crowns on everyone. We can slap on crowns on anyone we want, as long as they know this is why we're doing it, and this could be the consequence of doing it, if you're okay with that.
Awesome. So next we have Jake's question, which I'm sure you can see in the chat as well. How long do you give patients with interims to give feedback before sending impression or casts to the lab to fabricate the finalized restorations?
That's hit or miss. Typically, I just give them 2 weeks, to be honest. If I do a full mouth rehab case, I really focus on occlusion first. I make sure they go through every excursive movements. I make sure that they're not breaking their restoration. I give them acrylic restoration, so it's a little softer, and I want them to actually chew through that. I want to see if there are any pontic spaces or any areas or any crowns that are breaking, because that's a weak spot. And I want to make sure I navigate that. And also, of course, I need to make sure I have enough restorative room. So for me, I plan all of this first. If I plan this accordingly and my casts are nice and my diagnostics are good, and I prep accordingly and I manage their occlusion through every excursive movement possible. And of course, most important thing that people don't do is they don't take bites registrations, or they don't check their occlusion when the patient's upright, right? The most important thing when they're reclined, don't forget, gravity is not your friend here. Your jaw will protrude and it goes to centric relation slightly. So the bite is completely off. So how many times when you try to cement a crown, the first thing you do is you start adjusting the occlusion, right? Well, if you manage to bite, if you have them set upright, that's the most comfortable centric occlusive stop, right? So that's the first, they're not shifting their jaw too much or comfortable. So when you give the stuff to the lab, yes, you can pick up the triple tray and look through the light and say, hey, everything's biting accordingly, but are they biting accurately? So I always make sure my occlusion is just verified sitting up. And then I know when the bite is stable, they feel comfortable, and the phonetics is good. I let them ride out for 2 weeks. I'll finish the case right away. I don't even think about it, because if you manage that bite and understand that function and occlusion, there's no need for you to wait 2 months or 3 months or 4 months or even like a week. You can finish right away if you're comfortable.
Awesome, thank you. So it's almost 1:45, so we'll take one, maybe two more questions. I know you have to probably get back to work as well. And then we'll wrap it up, even though I have like 15 questions in the chat. So I apologize to everyone that we have not been able to get to all the questions, but a lot of people are saying you had an awesome presentation, which I agree. So I think for our last question would be, why did you do the optional second year of your residency, and what did you gain from it?
So I'm a huge self-reflector guy. So my first year, it was very good at delivering care. Like you were really good at prepping crowns. You were really good at prepping crowns, and then you're doing it for what? You took 45 minutes. Now you're at 30 minutes, so on and so forth. And after that, I didn't really learn much other than my speed, right? Which I was doing, which is great because it's important in prior practice. It's all about time. But most importantly, at the end of the day, in my second year of residency, because Bronx VA is known to be a full mouth rehab residency, where you do a lot of implants, you do a lot of, endo, you name it, the VA, I placed 120 implants. Like, that's unknown, like unheard of for a GPR, right? So I wasn't going to give us great opportunity to train surgically under perio, learn full mouth rehab under this great director for the sake of working in private practice. So I turned down a job to stay a second year so I can be better, faster, and understand dentistry and not do dentistry. Once you get to the point where you can master and understand every step along the way, whether it's full mouth rehab case, which will destroy your brain will be mush, because understanding full tiny angle abutments, full mouth rehab, ligating, whatever stuff, all that full mouth rehab case, like, you're not going to see that in private practice. But if you do come to see a patient like that, can you take on this case, right? So I spent a lot of my time understanding occlusion and dentures. Actually, I spent a lot of time learning about removables, because the dentistry is going to help you master aesthetics. Think about it. You have a dentureless person, and how do you manage just give them the denture that's fitting really well, occluding very well, functioning very well, and aesthetically pleasing? That's full mouth rehab. That's aesthetics. So I really spent a lot of time learning about dentures from the lab. So at the Bronx VA, we also had the benefit of having an in-house lab. So I was working and sitting down with the lab technicians, learning about what they're looking for in cases. So this way, moving forward, when I'm in private practice, I can think like the lab technician and give them quality work for quality results. So that's why I spent 2 years instead of 1 year. And honestly, it was the best. I wish I could stay a third year, fourth year if I could.
Awesome. Well, thank you so much for your presentation. So right now we are putting up the launch code for everyone to take down for the raffle. If you have 1 more minute, everyone feel free to go if you have to go, if you want to take your break. But there has been a question that I've gotten a lot in the chat, and it's about the longevity of composite restorations versus veneers and why you choose to do composite when they tend to stain. So if you just want to answer that quickly.
Oh, sure.
Awesome.
Yeah, absolutely. With composite restorations, at the end of the day, once you prep those teeth, you're never getting them back again. I'm a huge believer in that. If someone wants to change, if they're 80 years old and they look like A1, damn, you got to prep those A1s off. You got to put some A3s on, A35s. I don't want to get to that point. I want to be able to have this composite last a long time. Will they have the same longevity? Probably not. But at the end of the day, I know I did the best conservatively. Right? I'm not breaking the bank for the patients. They're going to walk out extremely happy. Is it the best? Is it going to be like porcelain veneers? No, but sometimes you want to make sure you're not opening a can of worms with patients, because when you prep those teeth and you get veneers on, if they're not happy with that color, you better bet you're sending that back to the lab, get another shade match, bring it back, try it again, don't like it, send it back. You're actually spending way more time if you don't understand how to manage porcelain veneers. And I rather just kind of set my expectations clear. I'm just looking for an improvement. I'm not looking for perfection. If you're looking for perfection, you should go pay someone, $2,000, $2,500 per veneer to get that done. But I'm going to help you out as much as I can to improve your smile. If you're happy with your smile as a result, that's all I have to care about, because I've helped them. So that's why I choose that. And composites are nice. So far, it's been a couple years. I haven't placed any composite. It's been 5 years, and no one has really complained about color change.
Awesome. Thank you so much. This was such a thorough presentation. We really enjoyed listening to you speak and doing it on your lunch break. I really, really appreciate it.
Thank you.
So I'm going to stop the recording now.